or lung function tests and so forth that are easier to do periodically. This is still not a tool that is easily amenable or accessible to a lot of people or physicians within the United States. We're using it in clinical practice, but a lot of other centers are predominantly using other tools, the ophthalmoscope or dermatoscope, and sometimes, the clarity and ability to count capillaries, be more specific with quantitative measures is much more difficult with those tools rather than this. This is that is why this is considered the standard of care, the best research tool, because you can get a very, very clear picture on the number of hemorrhages, number of capillaries within those. You can see those very faint green lines. They are 1 millimeter surface area on the nail bed, and that's what happens in research. Those numbers are counted within those two lines and done periodically to assess changes over time. Yes?
Just wondering what your thoughts are on LDN.
Thoughts on?
Low dose naltrexone.
I think this is probably beyond my area of expertise, but you have a really good talk coming up that will review this in much, much more detail. Cine, scleroderma, yes. So the question is that we're familiar with the diffuse and the limited cutaneous scleroderma, but what is cine scleroderma? So as you know, patients with scleroderma is scleroderma, thick skin, which is one of the more pronounced manifestations of disease, which is how we classify the limited and diffuse subsets, mainly on the extent of involvement. So if the involvement is distal, the skin thickening is all distal to the elbow in the upper extremity, distal to the knees in the lower extremity, we call it limited. But if it's affecting the upper arms, the thighs, the chest, the trunk, then usually it's the diffuse variant. On the other hand, the patient may have no skin disease at all. So their skin pinch, their skin texture may be completely normal, and they may have esophageal dysmotility, pulmonary arterial hypertension, interstitial lung disease, raynaud's, digital ulcers. They may have many other components of scleroderma. They may or may not have the scleroderma blood markers. Some of them have it, others don't. But that's very helpful if they have it, because then it's easier for the diagnosis to get clinched, but many don't. They may have a positive ANA or anti-nuclear antibody test, but may have no skin disease at all. On the other hand, their internal organ manifestations are classic for scleroderma, and so that is the variant that's called systemic sclerosis, cine scleroderma, which means they don't have the skin thickening part of it. Yes?
Have you had success in using Voltaren gel or diclofenac, or do you prefer oral NSAIDs?
I actually really love topical diclofenac. It is really a good strategy for patients who it works for. It doesn't work for everyone. Oral non-steroidals have their own fair share of problems, and whether they be, our scleroderma renal crisis patients with renal insufficiency, or those with a history of cardiomyopathy, but cardiac risk in general with regular, consistent non-steroidal use, as well as heartburn that comes along with it, gastritis that can develop with NSAIDs. So I am not a big fan of non-steroidals. I of course use it judiciously in circumstances where I absolutely have to resort to, but for my patients who have osteoarthritis, I use a lot of topical Voltaren gel, often for their small hand joints, but knees. And I tell them to use it at other areas if they feel they get some benefit out of it. So It's probably the least invasive strategy with a lot of benefit for a lot of patients. So where it works, I think I have full support in using that.
Well, thank you so much.